A very special speaker with a very special talk. This is Dr. Naveen Pemmaraju, who is a professor of medicine at the MD Anderson Cancer Center. He's also the executive director for the Cancer Center at the MD Anderson Cancer Center Cancer Network. With that being said, it's my pleasure to introduce Dr. Naveen Pemmaraju to speak on next generation JAK inhibitors and promising new drugs. A little bit of overlap with earlier talks, but there will also be some new things happening too that Dr. Hoffman didn't include. So,
thank you. Thank you, Dr. Ghaith and Cornell team and CR&T team. In honor of Dr. Silver and our colleagues, as we've heard here, it's really an honor for me to be here with you. And as I look around, I know 95% of you, okay? So the 5% that I don't know, no, I'm just kidding. Declare yourselves. There you go. I don't know you. There you go. So what I want to do is two things here. I love what Dr. Feldman told us, which is repetition is the adult memory's friend. But more than repetition, we purposefully had a few slides to show it from a few different angles. So Dr. Hoffman nicely started us out with giving us the framework from the biology, what's happening at the level of the cells, both in the healthy and in the MPN state, both. And then he did give us a nice preview, and I'm going to show some of the same slides purposely for you because now after the morning's reflection, where do they fit in your mind? But my emphasis is not only for you as patients, but also for the caregivers and the family. Because as Ruben so eloquently said, caregiver fatigue, family fatigue, whatever you call that, that is such an invisible, draining force that it permeates your relationships, your own sense of well-being, and your own program. And so this is dedicated to all of you as well. In this talk, I want us to actually, let's get a few items of work done. I want us to make sure we know the 4 approved JAK inhibitors that are already there. I want us to talk about the novel agents that Ghaith and the team have nicely asked me to talk about here. And then also let me focus on what you've already been hearing about these JAK2 and CALR therapies. So let's get right to the clinic here. So those of you facing myeloproliferative neoplasms, as we all know, and we've been talking about all morning, polycythemia vera, essential thrombocytosis, and maybe even early primary myelofibrosis or prefibrotic. Vascular events, as Hans, as you just nicely told us, is really the most important thing, bleeding or clotting. But unfortunately, as we start to develop myelofibrosis, I think the triad of constitutional symptoms or B symptoms that you either have been facing or you thought was due to aging, it may be due to the disease, the tumor burden, night sweats, weight loss, unintentional fevers, progressive organomegaly, so spleen and liver, I think of them as military reserves that come back into action if the bone marrow is starting to fail. You were making those cells inside mother's womb, and so they come back to help. That's fine for a short term, but if it's long term, then that is what's causing those organs to swell and the bone marrow is not doing well. And then, of course, anemia and thrombocytopenia, low red blood cells, low platelets. Unfortunately, as we all know here, once you get to the myelofibrosis, it's variable. Some people can live decades, low risk, intermediate 1. But as you get to intermediate 2 and high risk, the secret worry that you may have if you transform or you already have is, does that reduce my life expectancy? And unfortunately, it can. That's why we're meeting here today, and I think it's important, either from the myelofibrosis itself, transformation to acute leukemia, or infections or other things that could happen. And so that's why it's important to talk about the landscape of treatments and what's coming, and I hope to deliver a message of hope and positivity to you throughout. So let's begin our work here. So among the approved agents, let's start with the PV and ET. This is simply amazing effort by our colleagues, many of whom are here in New York. So the 2 standards for ET and PV, if you're considered to be needing treatment, are hydroxyurea and interferon, as we've been hearing. Many of you are on these drugs. The problem is we've never really compared them head to head, right? Which one? They're apples and oranges. One is oral, one is an injectable, one has flu-like side effects, the other has et cetera. I think the problem is that it's not going to be necessarily the purview of the pharma companies. It's going to be all of us here. And so this is a monumental effort. This is the MPD-RC, and I think this is really notable. So Dr. Hoffman, Dr. Ruben Mesa, others, John Mascarenas, all of you in the room who've been supporting this. The good news is these trials have started. I think they're going to take years and years of follow-up, but you can see here we randomize people to either hydroxyurea or the pegylated interferon, looking at complete remission at 1 year. What I can tell you so far is these trials have started. So a couple years into it, we're gonna obviously see equality or non-inferiority. But the question is, as we follow it longer, past 1 year, 2 years, 4 years, 5 years, as Hans and others have shown us, are we decreasing the inflammation with the interferon? And as you and Dr. Silver have shown here, interferon really looks like it benefits people in the long haul. And then the convenience of hydroxyurea, which may or may not modify the disease as much as we want to, but it's a pill, it's cheap, it's available. So I want you to know that this study is ongoing, and I think it's going to tell us a lot. For the novel agents in ET, I'm really proud to show this data to you, hot off the press. Ruben presented this very nicely at ASCO, which is the major cancer meeting in the world over the summer. And you should know about this data regardless of your MPN state. It's called the SURPASS-ET. And what they did is they took the newest form of interferon, that's called ropeg interferon, as you know, or Bezremi is the trade name, compared it to anagrelide. And these are in patients with ET who've already had prior hydroxyurea, one line of therapy. And very, very nicely, they showed in a large study, so it's a randomized phase 3 study, really the ropeg interferon outperformed the anagrelide in every measurable thing that we care about. And the summary for the ropeg is that not only it was safe and efficacious, but that could this be a new standard of care in second-line ET? It's already approved for polycythemia vera. Some of you are already on it. And so just 48 hours ago, it just got published in one of our major journals, Lancet Hematology. And I hope that we do see this as what you would call a label expansion or approval shortly. Why is this important? Ropeg is every 2 weeks rather than once a week, as you know, with the Pegasus pegylated interferon. And then it spaces out to monthly later on. So maybe more friendly for the patient, certainly a very efficacious drug. And all of us in the room are becoming very familiar with the long-term side effects of these interferons. The future of ET, which has been a dormant area of research, thanks to all of you, is now really exciting. I'd like to highlight, it's not inclusive, it's not comprehensive, it's a short talk, but at least you should know the vocabulary. The LSD1 inhibitors, some of you knew LSD1 in college. No, I'm just kidding. I think it's different, okay? I think it's different. I didn't inhale. You got to laugh at some of this stuff. LSD1 inhibitors. So this is what we call an epigenetic program. So maybe in a way it's influencing the tumor DNA. This is a well-tolerated group of oral drugs. So bomedemstat is the lead agent here. Can you believe it's already in phase 3 randomized trials? So meaning if it's positive, it could mean an FDA approval. So you should know about this drug in the works in both frontline and relapsed ET. So this is something that may not be on your radar. Bromodomain or BET inhibitors, we won't cover much here. Some of these drugs have some toxicities and they're going in and out of development, but I still believe in this class of drugs. So let's keep our eye on those over the next years. And then very exciting, a lot of the speakers today have mentioned the mutant CALR-directed therapies and mutant JAK2. The reason why this is important, just to remind you, so the JAK inhibitors that are approved now, Rux, fedratinib, PAC, and momelotinib, are not mutant JAK inhibitors. They hit the whole pathway. We call that wild type in the scientific. So it means it hits the whole JAK-STAT pathway. So, doc, why does ruxolitinib work in CALR mutated or MPL mutated or triple negative? Now you know why. It's not hitting the mutation, it's hitting the pathway. These drugs aim to really hit the mutation. So think predator drone right into the area, boom. CALR and mutant JAK2, brand new class of drugs. They're in what's called phase 1. I won't show you a lot of data yet, but in the coming months and year, we will see a lot. So that's for ET. Again, high platelets, cancerous cause, JAK2, CALR, MPL make up 90%. There's some active areas going on there. Very exciting is polycythemia vera. And I think this is interesting because it's been around for so long. Osler described it. It was described even earlier than that. Let's take a look at this. If you have P. vera in 2025, you've likely heard of hydrea or interferon. So the same question for ET. And then, of course, phlebotomies, the barbaric, outdated Middle Ages. Yes, we don't use leeches anymore, but I think even worse, you wait around all day for someone to draw your blood. And baby aspirin, great. And thanks to Dr. Feldman and our cardiology colleagues, a great addition. But I think we can do better than that. I think we can do better. In the last decade, we've had 2 approvals for PV. Some of you are on these drugs. The ruxolitinib, which you know from myelofibrosis, also has an FDA approval for PV. It's specific. It's after hydroxyurea intolerance or failure. And then the ropeg interferon, the Bezremi I just mentioned, actually initially got approved for PV 2021, middle of the COVID pandemic. And now, hopefully, in the next year, we hope to get the expansion into ET. But, ladies and gentlemen, there's some new drugs, and I want to highlight them to you in this talk. Hepcidin modulators. Hepcidin turns out to be one of those things you learn in biology class and you forgot about. And now it's like, oh man, that was important. It's the master regulator. It's the headquarters of iron homeostasis in the body. And if you have P. vera, and if your iron levels are messed up one way or the other, you may have red blood cells in the wrong place. So the lead compound there has been rusfertide. I'll show you that data. And now there's at least 4 or 5 other molecules and companies that are involved in this space. MDM2 inhibitors, HDAC inhibitors, LSD1. So some of the same letters and numbers you're seeing. I think the alphabet soup is just important to say there's lots of companies, lots of stakeholders, and more importantly for us in this room, lots of new options for clinical trials. As you all know, sometimes they hit, sometimes they don't. You may not hear about these a year or 2 later, but it doesn't mean we shouldn't investigate and let's see how these do for our patients. Why do we have to do novel drugs? I think it's important. Rather than being excited about them, we should understand why we're meeting. One of the reasons I think we should be meeting today is that the current standard of care, if you'll allow me to say, is inadequate. I don't like the side effects many of you have to face. I love the interferons. Here we are in the house that Dr. Silver built. I'm one of the biggest proponents. But the side effects and contraindications, even in my experienced hands, sometimes it's a difficult drug for some of you. I do start low and go slow. I think that's helped a lot of our patients. We do counsel for the psychiatric, liver, thyroid, autoimmune, skin, etc. And a lot of times with education and a caregiver and family, you can get through the first couple of doses and do very well. And again, if you start at a lower dose, almost all my patients can do well. Hydroxyurea, not a benign drug. Leg, mouth ulcers, people get fever, skin problems. Another reason we need novel agents. And even though the Rux has been a game changer, especially in myelofibrosis, the triad of weight gain, which can be dramatic in some patients, non-melanoma skin cancers, squamous cell and basal cell, which necessitate almost all my patients to see the dermatologist at some point, and infections such as shingles and herpes zoster or other infections, may not necessarily always be life-threatening, but they can cause quite a bit of problems and even hospitalizations. If these 3 drugs are the workhorses for ET and PV, I think we can do better. One of those classes, as I promised you, is that of hepcidin, mimetics, and modulators. So this is the rusfertide agent. The principle is that in P. vera, this abnormal state, your iron levels, the distribution of your iron and red blood cells is wrong. You have too much red blood cells in the circulating blood, clogging you up, and it's not enough of it is in storage. So we're doing phlebotomies to try to physically bring it down, maybe chemo medicines as well. We're not curing the disease, as you all know, and it's intermittent at best. So this class of drugs aims to mimic that endogenous protein, hepcidin, give your body a look at that. Body sees hepcidin. Okay, let's calm down this red blood cells that's too much in the circulating blood. That goes back into storage, back into the bone marrow, liver. Thank you very much. Now the patient doesn't need phlebotomies, and we hypothesize, hopefully by doing that, you don't become relatively iron deficient like you would with phlebotomies, and hopefully, maybe, you might feel better. Let's see what happened. So we took it to the clinic. This is the phase 2 led by Dr. Andrew Kirkendall, Dr. Marina Kremenskaya, and myself, with Dr. Hoffman and Dr. Yelena Ginsburg's essential biological contributions and clinical. This was the REVIVE study. So this is rusfertide, the lead compound. It's a weekly self-injection. So maybe like interferon, you can do it at home. And what this study showed is that in this population of patients, it's less than 100 patients, you had to be phlebotomy-dependent P. vera, 3 phlebotomies in the prior 6 months, or 6 in the prior year. And ultimately, what we showed is that the majority of patients became phlebotomy-free, and also it's a safe, well-tolerated drug. These results already in the phase 2 were published in the New England Journal of Medicine, just again indicating that there was a lot of acceptance from our academic colleagues that this could possibly be game-changing, but of course you have to confirm it with the phase 3. So the phase 3, known as the Verify, again led by myself and Dr. Kirkendall, we did an international phase 3 placebo-controlled study. So that's rusfertide, this new agent I'm telling you about, plus whatever you're on. 56% of the patients are already on Hydrea, Rux, or interferon. Okay to stay on there as long as you're still phlebotomy dependent. Versus placebo, which is no study drug, but again, you're okay to stay on whatever you're on. Phlebotomies, Hydrea, whatever you're on. So a true double-blind randomized control study with one variable, rusfertide or not. 293 patients, lots of sites. And what we focus on here is the weeks 20 to 32. Can we make you phlebotomy free, which is the key primary endpoint? Can it stay that way? And can you feel better? Is your fatigue better? Are you feeling a little bit better? So primary endpoint worked out with the regulatory agency is this part 1A that I'm going to show you here, weeks 20 to 32, and then these key secondary endpoints. Again, fatigue, symptoms. Ruben has pioneered that field and showed us beautifully this morning. I think nicely we added 2 symptom scores here, PROMIS and the MF symptom score. Okay, so 293 patients, briefly, just to show you the top line data, all the way up to age 86, so a real-world distribution of PV patients. The red box is to show you that, my goodness, there were people who really required phlebotomy, 16 phlebotomies in the prior few months coming onto the study in the rusfertide group in some of the patients. All right, so phlebotomy-dependent PV, 293 patients. What happened in the study? Very nicely, 77% of rusfertide-treated patients out of the 147 achieved the primary endpoint, highly statistically significant, versus only 33% in the control arm. And side effects, any new drug, make sure you look at the side effects. Very well tolerated. It's a weekly injection, some injection site reactions for sure, we saw in the beginning especially. Some people overshot, which literally means the drug worked too well, so you went from polycythemic to anemic, so you have to adjust the dose. I guess that's a good side effect to have. That's pretty good. We did the study during the COVID-19 era, so 2020 through 2025 for the phase 2 through 3. Overall, we need to follow longer for thromboembolic events, right? I'm just showing you the first 32 weeks here, so not many yet. So guys, this was actually shown, Dr. Kirkendall showed it for our group at ASCO plenary session, which is the highest honor in all of our cancer community. It was well received. And now we've completed this phase 3 trial. We're finishing up the data. He'll show the 52-week data at ASH, so stay tuned for that. And then let's try to work with the regulatory agencies to see if we can bring this to approval in the coming 1 to 2 years. Limitations of this, what you should be thinking about, it's a weekly injectable. Okay, our field's kind of used to that with interferon. But if you miss a couple of doses, there is the chance that the hematocrit can rebound up, so that's important. I think it's good that we included over half the patients were already taking their other thing, right? So that's good. That may be how it's used in the community. Does it modify the stem cell compartment? Does it reduce blood counts? Does it reduce the VAF? We have to follow longer to see that. Quickly turning to myelofibrosis, the 4 approved JAK inhibitors. Ruxolitinib, we just mentioned JAK1, JAK2. So this is approved for MF, PV, and also interestingly, it's got other approvals, GVHD, graft versus host disease. It's a very pleiotropic, nice drug. Fedratinib was approved in August of 2019, and this is also a JAK inhibitor. You should know that the Jakarta studies proved its efficacy either as a frontline agent or, interestingly, for the first time after ruxolitinib therapy. That's the one that does have a black box warning for encephalopathy, so it can cause some problems with the thinking, brain fog, and so we have to check the thiamine level and give thiamine for patients getting that. And there are some GI side effects. Pacritinib was the 3rd approved agent you should know about. Interestingly, this one was approved on the basis of platelets below 50 in February of 2022. It's an accelerated approval we've been using in the clinic. There's a Pacifica trial that needs to confirm it. Some GI side effects, particularly in the first few weeks or months. You have to watch out from a cardiac bleeding standpoint, but a nice drug, particularly if the platelets are low. Momelotinib is a very important drug, the 4th and final, led by Ruben and Dr. Verstovsek, Aaron Gerds, and others. A JAK1, JAK2, and ACVR1 inhibitor. Pacritinib also hits ACVR1 because these two can be delivered in the setting of low blood counts and maybe actually improve it. In the case of momelotinib, improving the anemia. In the case of pacritinib, being able to be delivered in the setting of thrombocytopenia, maybe also improving the anemia. The momelotinib, as we saw earlier today, is now approved in myelofibrosis based on the MOMENTUM study, along with SIMPLIFY 1 and 2. I think as we talk about the novel agents, we have to make sure we remember the past. So this is the COMFORT studies led by Ruben, Serge, Claire Harrison, and others. So the primary endpoint was this SVR, spleen volume reduction at 24 weeks, 35% or more by imaging. So just remember the number 42% was ruxolitinib versus almost nobody in the placebo arm, and then the TSS symptom score pioneered by Ruben shown here, which is an essential part of our drug development. But the problem, as we saw this slide earlier, is that prognosis after Rux, for some of us, can be devastating. And that means a chronic disease can go to an acute one. Some studies show a devastatingly low survival of less than 2 years in a highly select group of patients who have high-risk features. And what I want that to remind us is we have to keep looking for novel agents. Our colleague, Dr. Palandri in Italy, did a study, 218 patients. She found that at 3 years, almost half the patients are off their ruxolitinib, and almost all of them for bad reasons: infections, adverse events, progression of the spleen, progression of leukemia, death. Only a few people came off for good reasons, like going to a stem cell transplant. They concluded that if you had to come off Rux for a really serious reason, your median overall survival was only around 13 months. That's not good. And the people who did the best were, of course, the people who were both healthy and fit enough, right, to show up for and take investigational agents. This is the argument I put forward to you, that we need novel agents. So our group here, it was a combined US-European group, so several of the speakers here. What we wanted to say is, what can we do to do better? And we came up with 3 or 4 tenets. One is, do we need maybe perhaps treating the myelofibrosis earlier before it gets to the advanced stages? That makes sense. 2, maybe combining the JAK inhibitor with a novel agent. That's very nice. We've never had an approved combinatorial strategy. Or 3, harnessing the immune system, including stem cell transplant or novel immunotherapeutic agents, or those beyond JAK inhibition for patient benefit. And so as you look at this, stem cell transplant's the only approved strategy that's immunotherapy-based, I guess, or not approved, but just done. It's the OG, original immunotherapy. Yes, it's the only curative strategy I have for you right now, but I can't do it in ETPV. You can only do it in a select group of MF patients. I would say only 15 to 20% of my patients go to stem cell transplant because of its attendant risk of morbidity and mortality. So you have to be fit enough, you have to have a donor, you have to have logistics, you have to have support. This is a great strategy, but for a limited few. So how do we harness the immune system and go beyond JAK inhibition? Lots of agents. We made this slide a few years ago. We have to update it in a good way. We used to borrow from MDS and AML, but now we have a lot of drugs. Think about them outside the cell, at the cell surface, outside the nucleus, inside the nucleus. And so we have several combinations, some of which we took to phase 3 and didn't work out for various reasons. I led the navitoclax study, BCLXL. The spleen volume was very much significant, but we did not hit the symptoms. We did not make patients feel better, so that appropriately was not FDA approved. But we have a couple of other combinations ongoing that I want to show you. Manifest-2 is the bromodomain BET inhibitor pelabresib. This is still ongoing. We'll see extended follow-up, 72 into 96-week follow-up at ASH. This is where you take the pelabresib oral agent versus ruxolitinib. So Pela-Rux versus placebo-Rux. Again, it shows SVR improvement, but the symptoms didn't quite hit p-value significance, and that's important. That means they're studying this drug further and then developing a new trial to see if they can confirm the positive results. The second one we heard mentioned was selinexor, so that's an XPO1 inhibitor. This is the Sentry trial, which just recently completed enrollment, 350 plus patients, frontline, 2-to-1 randomization of ruxolitinib plus the new agent versus ruxolitinib and placebo. A lot of these new agents can have GI side effects, nausea, vomiting, so we have to watch out with you, and some of them require preemptive nausea, vomiting, diarrhea therapy. Yet another strategy is with MDM2 inhibitors. This is important, the POESIS study, because you add on to the ruxolitinib, and a lot of this work was done by Ron Hoffman and colleagues showing that MDM2 inhibition may be helpful for our patients. Imetelstat is the first-in-class telomerase inhibitor. I love this study for you, actually, for the patients and caregivers. It's the first study we believe in our field, large study, phase 3 randomized in the relapse setting, that primary overall survival is the endpoint. So Ruben said we need to live longer, we need to live better. This is notable. Now let's see how this trial reads out. What is the implications on that? But overall survival as a primary endpoint for the first time. And then finally, the new class of drugs that Ghaith asked me to mention, the PIM kinase inhibitors, a new class of drugs that's not yet FDA approved. And then again, you heard about the excitement with the CALR. What I want to point out is this particular drug, the mutant CALR, is already in the early phase 1. We've seen the preliminary data at EHA. We'll see more data at ASH. It's an outpatient drug. It's an injection every 2 weeks, outpatient, well tolerated thus far. Early results are encouraging, but it's phase 1. That means it's early. We're just looking at safety right now. Let's follow this over the coming years. Mutant JAK2, we're starting to target. All of these drugs so far are oral. As I mentioned, they hit the mutation specifically, not just the pathway. And then there's another drug that was developed here in New York, the Ajax, which is a type 2 JAK inhibitor. We heard most of this earlier, so stay tuned for these data. And so I think we can conclude by saying we have activity in ET, PV, and MF. Don't forget about the rare of the rare diseases, which I have a special passion for, such as the 8p11 syndrome, pemigatinib. So we're working on diseases that may only affect 100 people all the way up to thousands of people. Combinations, new JAK inhibitors, new CALR, new immunotherapies. Thank you very much for your time.